Hi, this is Sebastian Rushworth. Welcome to my podcast, where I talk to the most interesting and original thinkers in health and medicine. My guest today is Dr. David Unwin. David is a primary care physician in the UK, and for the last 8 years he's been running an ongoing study of his diabetes patients, where he treats them with a low carbohydrate diet. And this study has generated massive amounts of interesting information, and David's achieved some pretty remarkable results with his patients that have resulted in him winning multiple awards over the last couple of years. So in this conversation, we discuss exactly what it is he's been doing with his patients, what type of low carb intervention he gives them, and we also talk about some of the traditional criticisms of the low carb diet and why they really don't hold any water. This is a conversation that I personally learned a lot from, and I hope you will too. So please enjoy my conversation with Dr. David Unwin. Hi, David. Thank you so much for coming on and talking to me today.
You're so welcome. I'm fascinated to see how this discussion with somebody I've never met before is going to develop.
So I've been following your research for a few years, and I'm interested to find out how you came to develop an interest in low carb, high fat in the first place, and what made you decide to start producing research in the area.
I suppose it goes back a long way. Why did we all become doctors? Why did you become a doctor? And I became a doctor with a hope of making a difference to my community. That was me when I was 24. And then as the years went by, I became steadily more disappointed with what I was achieving. Because really, people never look much better. So, you get your occasional saving somebody's life, with antibiotics and they've got pneumonia or something. But I was bogged down with chronic disease. And I found that I was prescribing more and more drugs. But the patients weren't that grateful because they weren't that much better. And I started to become disillusioned, and at the same time a little suspicious about some of the benefits of the drugs I was using, and whether people really did live longer or whether they were much better. So that was the backdrop, really, where I was. So I was 55 years old, and I was thinking about retiring. I knew what was in the pension pot. I was ready to go. And then there was a few eureka moments, I think, that happened all in one year. My wife, Jen, had been a lifelong experimenter with diets, a yo-yo dieter. She'd been big and small and medium-sized and big and small and medium-sized ever since she'd been a teenager. And then she read a book about the low-carb diet, and she was nagging me and saying, "This is amazing, you've got to read it. The physiology alone will really fascinate you." And I read the book on low carb. It was by Dr. John Briffer, Beat the Diet Trap. And I was fascinated. I was really, really interested. And I could see that Jen looked much healthier. And so as an experiment, I went on the diet myself, just as an experiment. I was middle-aged. I had middle-age spread. I had high blood pressure. I was very lethargic. I remember I used to need a little lunchtime sleep, or after lunch I would need 20 minutes sleep on my own consulting couch. So I used to draw the curtains round. I was senior partner, so I just pressed do not disturb and have a little nap for 20 minutes. And that was the food making me sleepy. And all of this stopped within about 2 weeks when I went low carb. And then I did a really unusual thing. Dr. Briffa's books were discounted, sort of very cheap, and I bought 20 copies and I gave them to patients as a gift. And they were amazed to be given anything by their doctor. But I thought, I just said to them, I want to know what you think about that book. Read it and let me know what you think. And then they started coming back, just like me, saying, well, I feel amazing, a lot more awake. Particularly not hungry was a thing they said, and they were losing weight. And some of them had pre-diabetes, and we found that their blood sugars were improving. So we had this initial cohort, really, of the 20 people that I'd bought the book for, and Jen and I, and with encouraging results. But then there was trouble. Because this was before low carb was as commonly taken up as it is now. And even though I was senior partner of 9 doctors, the partners didn't like it. They really didn't like it. And they said that they said, well, a lot of things. Partly they felt I was wasting time. They said, you're wasting time on these people. You know, you're paid really to see sick people, and they didn't know why I was doing this. They were worried about the results, particularly lipid profiles and so on. And it's a funny thing, but those fights with my partners really have helped me and many people ever since. Because that's how I realized that if you're going to do something unusual, you need to collect data. And I'd say to all clinicians, actually, data is power.
Have you considered that? I mean, you stumbled on this thing that I guess people have stumbled on several times in history. That Atkins stumbled on in the 1970s, and you kind of went ahead and did the same thing he did, except that, I mean, what he didn't do and what ended up causing him a lot of trouble was that he didn't gather data in a systematized way. He never tried to publish in journals. And so when people asked him for the evidence, because he was saying the same thing you're saying, I saw these fantastic results with my patients that kind of the standard dogma would say or it's impossible, and then when people turned around and said, okay, well, show us the evidence, he couldn't do it because he hadn't gathered the data in a systematic way.
I'm so grateful. As I say, it's funny how in life I was arguing with my partners, and now 2 things: they're all low carb, bless them, and the practice manager, even the midwife, she's lost 4 stone. So they're all low carb, but I'm so grateful to them because they asked me about things like ethics, things like evidence. And so I was desperate to prove to them that I wasn't a fraud. And the other thing in the UK, in general practice, the computer systems are quite sophisticated and good at collecting data. In particular, we can easily produce graphs for individual patients of their progress. So I was constantly going in the doctor's common room. We have coffee together every morning at about 10:30 with graphs saying, you know, and I remember one day I had 100 people who were lighter at that point than they had been for 20 years. I had 100 graphs proving. So I'm so grateful, and you're absolutely right. For anybody, if you're going to do an unusual thing, you mustn't blame other people when they're suspicious and wonder if you're telling the truth. You should collect data.
I think it's, kind of fantastic that, you show that, and I think most doctors probably think that, well, I can't do research unless I have a PhD, and then I'm a kind of a professor, and I have my own research group, and I'm getting lots of money and research grants, and you show that. I mean, you can really do useful research with a very limited budget. All that's really required is the will to do it, and you don't need this kind of academic setting and the research group and the $1 million grants in order to be able to produce valuable data.
Yeah. Well, and you see, the other thing is money is so often corrupting, isn't it? Because who's going to give $1 million, whatever you have in your country, let's say dollars, who's going to stump up £1 million for no reason? Well, maybe they want to prove the drug works, and maybe they won't bother publishing if it doesn't show good results. So my total budget to date has been £7,000. I was given £7,000, which is a tiny amount for 10 years' work. But of course, you do have to be very generous with your time. But it's so exciting and positive. And I think the other thing is that you can find academics who will partner you. So I've probably done, I wonder how many papers I've done now, somewhere over 10, I'd say, peer-reviewed papers. And usually what I do is I try and find a professor in whatever the subject is. So I've used different professors, because academic departments are quite interested in getting hold of free data. So for them, they get a publication out of it, and they tend to help me, and that they help me know how to write a paper, because it takes a long time. So the one, just to let you know how much effort is required to publish a paper. So my BMJ nutrition paper about 2 years ago, that took me a year to write, but there were 300 Word documents went into that. 300. So I was writing a new Word document more or less every day for a year. But that paper has made a big difference, and it is worth it.
Well, so we've talked about how you were blown away by the results you were seeing. So what exactly does the intervention consist of, and what were the specific dietary recommendations you were giving the patients?
So I start really with the idea that if you have type 2 diabetes, your metabolism cannot deal with sugar. And that I think it's generally accepted that having a high blood sugar is aging and bad for your arteries and bad for everything. And so it's fairly logical that we should encourage our patients to improve their blood sugar. And then it's only a very small step to the first thing you ought to do is not have sugar. Don't have sugar if you don't want your blood sugar to go up. And most patients they're not surprised by that advice. But the thing I had missed was that starchy foods like bread, potatoes, cereals digest down into astonishing amounts of glucose. And I totally missed it. Isn't that terrible? And I didn't think diet made any difference. But when I started advising them not just to cut out sugar, but to cut out potatoes, rice, breakfast cereals, and starchy carbs, so that there are things you're reducing, which is sugar and starchy carbs, and things you're increasing, which is green veg, meat, fish, eggs, full-fat dairy. So that, I suppose, is the diet. The diet has been published many times, and if anybody wants to have a look at the diet, we refined it down to a single A4 sheet, because my patients didn't want sheets and sheets to read. We got it down to a single A4 sheet, and the papers that I publish, I've always got it in there. So if you just Google BMJ nutrition and Unwin, you'll find probably one of my papers, and it'll have the diet sheet in there. So that's the diet. So it's low carb, higher protein, medium fat, I would say. So a quick way to do it is I'd say, cut out the white stuff and turn it green. So if you were going to have a steak and chips and broccoli, get rid of the chips. If you're going to have a curry, replace the rice with loads of green vegetables. And I think that helps me. I used to worry about, you mentioned the Atkins, and I used to worry about the Atkins because there didn't seem to be many green veg in the Atkins. So I used to worry what would happen to vitamin levels. Then the second part of your question, I think you asked what results, what it was. The very first thing the patients told me was that they weren't hungry. And one thing about general practice is you really know your patients. You know, at this stage, I'd looked after most of them for over 20 years, and they mainly tell you the truth. So when they say this is weird, this is the first time I haven't been hungry in decades. And when it was exactly what was happening to me, so I knew they were telling the truth. So that was the first thing. In terms of the blood results, improving liver function, I was really amazed. The liver function was improving in weeks. I had people who'd had maybe 3 times the upper limit of normal for liver function for 10 years, with normal liver function in a month.
Wow.
I remember one lady, and I'd referred her to 2 or 3 gastroenterologists because I was so worried about her liver function. And in each one of them, she was told off for drinking, and she kept saying, but I don't drink. A really respectable middle-class lady being told off. And one of them was in public because she was taken to see a lot of medical students, and the professor said, tell us how much you drink. And then he said, no, tell us how much you really drink. And that was in public. And that poor woman never got over that. But her liver function has been normal now ever since 2013. So it had been abnormal for a decade, because I've got all the data. Since she went low carb, been normal now since 2013. So the liver function has fascinated me. The thing was, there was loads of different things, and in the beginning I couldn't link them together. So I'll give them all to you and see if you can link them together. So I noticed blood pressure improving significantly, so much so that I think it's 20% of all the drugs for blood pressure I had to stop because people were feeling dizzy when they stood up. So I noticed improving blood pressure. I noticed that some of them had had swollen ankles for years. And I remember one lady, I'd had her on frusemide, which is a very powerful water tablet. I'd had her on frusemide for many years. When she went low carb, her ankles, which she'd been on the frusemide for her swollen ankles, became perfect. She'd never had them as good. So as an experiment, we stopped the frusemide, and they've been fine ever since. So patients were experiencing, they were passing a lot of urine. And that was getting rid of abdominal bloating, ankle swelling. And in the early days, even a few cases of heart failure improved. And then I was worried because I thought, well, they're having all this eggs and butter. So I was monitoring the lipid profiles. And as you'll see, if you take the trouble to read my papers, they improved significantly. So they didn't get worse. Weird, particularly the triglyceride level. Triglyceride is a cholesterol-like fat in the blood, and that improves by about 1/3. So that improved, and the blood pressure. The hemoglobin A1C, this is how sugary your blood is. So it's what doctors measure when we're looking at quality of diabetic control. The hemoglobin A1C, I'd never seen anything like it. And we started getting patients who were having levels of blood sugar that were not diabetic, so that we were getting remission of type 2 diabetes without using drugs. I remember the first case I saw of that, I was amazed, and now I've got 109. 109 people not using drugs with a blood sugar that's not in the diabetic range, having previously been diabetic. And it's led to amazing savings in our drug budget. So we're spending £60,000 per year less on drugs for diabetes alone.
Just for listeners who aren't doctors, how normal is it for a type 2 diabetic to go into remission in their disease?
Yeah, I'd never seen it in 25 years. I'd never seen it a single time working with a large practice in the north of England. I hadn't seen type 2 diabetes, drug-free remission. I hadn't seen it even once. What the usual experience of people with type 2 diabetes was that they gradually got worse and worse. And I started them on metformin, then I added another drug, gliclazide, and they got gradually heavier and sicker. And that, in fact, it's amusing really. I found the subject of diabetes so depressing. As senior partner, I gave the whole portfolio to a junior partner because I wasn't prepared to do it anymore because it was too depressing. And now they're my favorite patients. I'm so, I love working with people with weight problems and poorly controlled diabetes because I feel I've got something to offer.
Do you think in 10 or 20 or 30 years, or low carb has becoming more and more mainstream over the last 10 years, more and more acceptable, and doctors can recommend it to patients now without having to worry about losing their licenses. Do you think that at some point in the future type 2 diabetes will be viewed as kind of gluten intolerance is viewed now as a disease that's caused by some kind of dietary problem and that can simply be cured with a dietary intervention?
Yes, that's an excellent point. Richard Feynman calls diabetes carbohydrate intolerance. He was the first professor, I think, that I wrote a paper with, and he calls it carbohydrate intolerance. Isn't that interesting? I think there's a battle going on in the world. So we have the supermarkets and the food producers, and they'd like to sell you bread and breakfast cereal. They want to sell you something with a long shelf life and very cheap. And that's breakfast cereals and rice and all of these things. So they're very powerful. And then we have the drug companies who absolutely their share price depends upon requiring to sell lots of drugs. So those are the forces of evil. But then we have the truth, which is gradually leaking out. The most logical thing to do about a high blood sugar is to consume less sugar. And that's a truth, a simple truth, and it is leaking out. And I know now, the American Diabetes Association in Canada, in Scotland, all over the world, the various guidelines are saying that low carb is a completely relevant and potentially really helpful intervention. I think the players who may make a big difference could be the insurance companies eventually. Think about it. Who is paying worldwide for all the drugs and all the disability and the terrible death that's occurring? Far more people die every year of diabetes than die of COVID. Only it happens every year. And in developed countries, it's becoming that the insurance, a lot of people cannot be insured. So the insurance companies are not over happy about all of this and are beginning to interest themselves in offering their clients something like a low carb program because they don't want their clients sick. And that's very interesting. And I know insurance companies all over the world are beginning to actively seek people like me out to say, how's it done? And, could we offer it? And then maybe they could offer cheaper insurance policies. So the battle is a very, very long one. Although I never dreamt, I was very lonely at the beginning. I didn't know anybody else that was doing this. And now there are hundreds and thousands of GPs and doctors all over the world doing low carb. So I am hopeful, but we must never underestimate the powers of, enjoying junk food. I myself think probably a lot of foods are addictive. I have patients who continue to eat food that is bad for them, even though they know it may kill them. Isn't that the definition of addiction?
You mentioned that the cholesterol levels actually improved, contrary to what many people would expect, and I seem to remember seeing a meta-analysis of randomized trials of a ketogenic diet that found, I think if I remember correctly, that most cholesterol markers decreased, but LDL increased. Is that kind of what you found?
So the best meta-analysis I know actually came from Liverpool University nearby, and they found overall improvements in all the lipid markers. But it's true to say, if we're going to discuss lipids, I need to help the listeners a little, so that we don't just measure cholesterol anymore. So we've got the idea of low density lipoprotein, low density cholesterol, and high density cholesterol. The high density cholesterol is so-called the helpful cholesterol, and you want more of that. The low density one is slightly contentious. There are people who say it probably doesn't matter much, but there are many people who say, particularly if the particle is small, that may predispose to heart disease. So what is generally accepted in a lipid profile is that you will see significant improvements in the protective high-density cholesterol. You will also see even better improvements in another fat called triglyceride, which is clearly linked with mortality and morbidity. And then we have the discussion. Some people find a small increase in the LDL. That hasn't happened for my patients. So I've been monitoring them now since 2013, and the LDL hasn't gone up in my practice, and in fact improves significantly along with everything else. But other people with different populations have found out slightly different things. But I think generally there's agreement that triglyceride will improve and that HDL will improve. And in fact, a really good marker of cardiovascular risk is the triglyceride HDL ratio. And you can see that if triglyceride comes down and if the HDL goes up, in terms of what effect that has on a ratio, it's dramatic, really dramatic. I don't think we talk nearly enough about triglyceride. I really, really don't. I think in part, why don't we talk about triglyceride? So it's another fat in the blood. It's produced by your liver, particularly. I think we don't talk about it for the same reason that I didn't talk about it until 2013. And that was because I didn't really understand it. And also, I didn't know what to say to patients about a high triglyceride because the drugs don't help it. So I only had one thing in my toolbox, which was statins. Statins aren't terribly good with triglyceride, so I didn't know what to say to the patient, so I sort of fudged it. I said, we'll recheck it in a year and hope somebody else measures it. Isn't that shocking? Absolutely shocking. But now I really know what to do with a high triglyceride. I very, very rarely fail with a high triglyceride now. I've got some amazing results.
And apart from this cholesterol issue, another criticism of the low-carb diet is this idea that it's generally high in protein, that if you cut down on carbs, you usually compensate by eating protein, and protein can be harmful to the kidneys. How would you respond to that? I know you wrote an article.
I did. Well, I'll explain why I wrote the article on that. So I do a lot of public speaking, and before COVID, I went all over the world, and I was in Ireland, and a very senior dietitian stood up and said, aren't you worried about the renal function? Because if they've cut out carbs, they must be having more of something, and it's probably protein. And it was her opinion that protein was damaging to renal function. And that really worried me because the truth was I hadn't thought about monitoring renal function. So I was really sensitive to the idea they were having more fat. And so I'd monitored liver function, I'd monitored the lipid profiles and blood pressure. I hadn't monitored renal function. But I didn't remember many patients whose renal function had deteriorated. In fact, hardly any. And some of them had really improved. So again, it was my wife, Jen. She said, come on, you lazy thing. Just get in there, retrospectively go through all those hundreds of patients, which takes a while, let me tell you, and find out, because we've got the data. So data is power. So I went back through all the patients. I found the baseline renal function, and then I found the latest renal function. And the other thing I did, I found a professor of nephrology, Professor Wong of Liverpool University, and a very senior dietitian, Dr. Nicola Guess. And in the paper, we did two things. One was I got the academics to look at the evidence for protein, dietary protein, being damaging to people with average renal function. And you know what? It's all nonsense. It's all based on a load of rubbish animal studies in the 1970s. It's all based on work on vampire bats, guinea pigs, rabbits, nothing on humans. When they went back, they said it's surprising. There's hardly any real evidence in humans of this. And then we looked at my data. And bear in mind, the average patient is 63 years old with type 2 diabetes. So their renal function, so on average, my patients are on the low carb diet, let's say for about 3 years. So by the end of it, they're 3 years older and they've had diabetes. And we know that having diabetes ages the kidneys. So the renal function should even normally deteriorate for the duration of the diet. But actually, it went in the opposite direction. So not only did the renal function, on average, looking at the statistics, it wasn't that it didn't deteriorate, it actually improved. And in fact, it did exactly the opposite of what I might have expected. So I was really thrilled and excited. And again, it proved the value of data with all, as I say, the data in general practice, they're a mixed bunch, aren't they? They're on loads of other drugs. Some of them are fat, some of them are thin, and the rest of it. But this was hundreds of patients, and the p-values were very small. And you're always looking for a small p-value, which says it's very unlikely that the beginning group and the end group are the same. So very small p-values. And that paper, I was really proud of that. And it came out of just a genuine fascination, really, and also feeling a bit worried that I'd not thought to worry about that. So anyway, at Norwood Avenue, my practice, renal function improved significantly. Of course, these results these are people in primary care. This is not that I'm working in a renal unit with people with damaged kidneys, with very significant kidney disease. I can't answer that question because that's not the patients I have. But I can tell you that average people with type 2 diabetes and average renal function in my practice improve. So I'm grateful to that dietitian again. Although it seemed provocative, it was a perfectly reasonable question. And we shouldn't mind people asking us questions. And if you can't answer the question, you need to go back to the data.
So basically, to sum up, the criticism of the low carb diet, that it raises cholesterol and thereby causes heart disease, and that it damages the kidneys, is really kind of unsupported by the evidence.
Yes. Yeah. I don't think it's just the evidence either. Let's open up a new front. So I think I'm very interested in the idea that if you had a pet human, what should you feed that pet human for optimal? If you had a zoo and popped humans in there, what should you feed them for optimal health? And how do we know what our pet human ought to eat? Because we eat such different things across the world. And I think that paleontology helps us understand, because modern man is so recent that what we are, you and I, sitting in our modern homes, we're just cavemen, really. We haven't evolved significantly since the advent of agriculture. And so if we go back to pre-agriculture, about 4,000 years ago, what were the sources of carbohydrate? What was the normal diet? So yes, there were berries in season, but there were no refined carbs at all apart from honey. And you're not telling me that we were gorging on honey every day. It was a celebration when you found that bee's nest. So I think we must have been designed for certainly high fiber, lots of green veg, the berries, but I think there was a lot of meat there. And the current modern diet is way different. So the modern diet is actually, it's not that my patient's having a low carb diet, it's the rest of you are all having a high carb diet, because the modern junk-filled diet is high carb. It's the highest carbohydrate intake that humans have ever had in their entire evolution. Because just think about, what could they have eaten that has the glycemic load of cornflakes? Not possible. Boiled rice, not possible. You could say boiled potatoes, but there were no potatoes. The modern potato is quite different from what there was before. So that's my answer. So we have the science now. We've got RCTs, but we should also bear in mind our evolution and what's likely and what's reasonable. And I think the modern diet is a high carb diet, and I would say I'm trying to get my patients to go back to more of a normal carbohydrate intake, which is less than 130 grams of carb per day. And I'd be surprised if caveman would manage to find more than 130 grams of carb in a day. So even nuts and so on don't have much carbohydrate in. There's one or two roots, but they're not, you'd struggle to get a lot of carb out of them.
I think this is a very basic thing that most people don't realize. I certainly didn't realize until I studied medicine and went through how carbohydrates work and how they're structured and how human physiology works. The fact that food, rice, grains, cereals are extremely high in carbohydrates, and that to an extent eating white rice is not really very different from eating candy in terms of the effects, the physiological effects and the carbohydrates.
Yes, absolutely. And what's interesting, I did some work recently comparing, everybody thinks, eat brown rice or eat brown bread. But brown bread or brown rice is only about 1/3 to 1/4 better than the white rice. It still has a lot of sugar in there. And we come back to the starch molecule. So the starch molecule is made up of glucose. It's a polymer of glucose. It's glucose molecules holding hands, and digestion comes back and cleaves it back into very large amounts of glucose. And that was a simple fact that I had missed for so long. I never talked to patients about bread and breakfast cereal, and when I look back now, I'm embarrassed.
I guess one criticism that might be leveled at the data you've produced is that it's observational data, that it's a cohort study, obviously, I don't know, but the impression I've gotten is that the patients get kind of more follow-up. They get these group sessions, they get more attention than the average diabetic patient might get who goes to a primary care clinic.
Yes. I think what I'm trying to show is what's possible. And then when you get other GPs, and there are lots of them all over the world now publishing results. So if you can replicate something, it's probably true. So if I'd had just one patient and never replicated it, maybe that was a wrong thing. But now I've done it for hundreds. But then I've taught other GPs to do exactly the same. So this thing is you can replicate it. It's true to say that my patients might get more attention. But as I said to you earlier, if I'm spending £60,000 per year less on drugs for diabetes, that's a recurring saving. Even if you properly costed my time, you would still save about £30,000 per year if I was paid properly for the low carb work. So given that medicine is about helping people, and I have a model which works for my practice and works for other practices all around the world, incidentally. And it's a model that may save money and actually save lives. I think it's worth very serious consideration. I mean, a valid criticism, I've thought a lot about the criticisms of what I do because I take it seriously, of course, is that on the whole, people opt for the low carb diet, don't they? So that they are a chosen subset of the practice. Because, so people who opt for a diet, maybe they're the brighter ones or whatever. But what's interesting is now, so of the practice population, 39% have chosen low carb. So if you could get 39% of your country to choose low carb and you saved loads of money and you got the numbers of diabetes remission that I get, well, why wouldn't we do that? Maybe there are people who low carb doesn't suit, and maybe they'll have to have the medication, or they can have bariatric surgery, or they can use very low calorie diets. I'm not saying it's the only thing to do, but if people choose it and they like it and it works and you can replicate it and you can save money and then save lives, and given that diabetes is so terribly serious and involves so many millions of people dying, I think it's something really worth thinking about. And I suppose, the question for you would, if you had diabetes, shall we start drugs on you, Sebastian? Would you have bariatric surgery, or would you just cut the sugar?
I think I'd rather just cut the sugar.
Because we know that. So metformin, the commonest drug that we prescribe for diabetes, 20% of people that take metformin get diarrhea. Before I did the low carb, we were always referring them because we thought they had cancer for colonoscopies, because of the number of people. They don't get diarrhea at the beginning, but 20% of them after they've been on metformin for a while, and particularly when you increase the dose, get loose motions and bloating and one thing and another. And really, there are no medications, not many that I can think of anyway, that don't have some sort of a side effect or some sort of a thing. And as I say, if sugar is the problem with diabetes, then it makes sense to cut it back. And I did try the other way for 25 years, prescribing drugs. I really did that massively, and the results are very depressing, or they were in my clinic anyway. People just got heavier.
And do you think that the size of the effect you're seeing is so large that the benefit really can't explain by any type of confounder? Like you mentioned that it's the most motivated people who take part in the study, or that you have this extra coaching or anything else?
Yes, I think the first point is that we've now got 39%. So I'm in the National Health Service in a poor area north of Liverpool. I'm not in a wealthy area. So I think my patients, and the 9,000, so it's unlikely that we'd have 9,700 geniuses north of Liverpool. So it's quite a big practice. And then when you find that other GP practices, so I've got friends in London, in Scotland, all over, and in fact in Canada and America and Australia, achieving very similar results. If something can be replicated, then it may be true. It may be true.
I'm conscious that we've been talking for quite a while now, so I don't want to take too much more of your time. I want to ask you one final question, which is how can a doctor or a clinic that wants to start doing this in their practice, what's the best way to do it? I mean, how do you implement it in your practice?
Great. Well, there's also, I've produced a lot of resources. So with 16 other clinicians, we started a British charity called the Public Health Collaboration. So this is a charity, it doesn't make any money. If you Google Unwin and PHC, which is the name of the charity, it'll take you to the charity website. And on the resource page, I've loaded it with free stuff. So there's the low carb protocol for doctors and nurses. There is the diet sheet is there, the frequently asked questions. I've tried to, and the teaspoon of sugar equivalents, 7 of them, and they're translated into 14 languages for you. So there should be whatever language you require, and it's all free and not copyrighted. You could also Google and get any of my publications. Again, if you Google Unwin and BMJ Nutrition, you'll find my BMJ Nutrition paper. If you look in the supplementary data, in the supplementary file, I've chucked in as much free stuff as I can to help anybody who wants to replicate what I've done. And hundreds of doctors have done so. And it's all for free. Angels in heaven are singing every time a doctor has a go at helping a patient not to use drugs. So let's have some more angels in heaven singing. There we are. That's my answer.
Thank you, David. And I think that was a very good kind of final, good end to our conversation. Thank you so much for sitting down and talking to me today.
Well, you're very welcome.
Guess what? The full-length version of this interview is roughly twice as long. In order to get access to the full-length version, you'll need to sign up as a patron, which you can do at patreon.com/Sebastian Rushworth. Patrons get access to a private podcast feed with full-length versions of all the interviews I do. They also get access to my private forum and all the interesting conversations happening there. And they gain the ability to send me direct messages. I always respond to messages from my patrons. So please sign up at patreon.com/Sebastian Rushworth.